Hey, it's Rocky, and we have a special COVID episode today. We're going to skip all the formalities and jump right into the interview. Welcome to Rich Your Soul, Dr. Heilbron. It's great to have you join us today to share your knowledge on COVID.
Happy to be here. Thanks for having me.
Thanks. Can you just tell the audience a little bit about your background and what you do so that they have a sense of where you're located and your history with this?
Sure. I'm a general trauma and vascular surgeon that's been working here in Southern California for the last 22 years. My dad did it for 50 before me, same thing. I'm the current vice chief of staff at St. Mary Medical Center in Long Beach, but I've been previous chief of surgery, chief of medical quality, and a bunch of stuff like that. And I've been sort of in the media around here in local Southern California, radio stations, newspapers, televisions and stuff. I think it's sort of part of my job being a doctor is also talking to my patients and talking to people about sometimes kind of complicated things.
And that's what we're here to talk about, a very complicated things. So you are in the hospital. Can you tell us what is it like right now in hospitals?
Actually, this is my 52nd day in a row of either being in the hospital or being in the office. And because of all the stuff that's going on. And I have to be honest, it's pretty stressful. I recently spent most of the weekend in the hospital and in the ER. And one of the things people kind of forget is it's not that coronavirus isn't serious. Just for us, it's another serious. So we still have the heart attacks coming in and the car accidents and the strokes and all that stuff. And on top of that now, there's this added level of tension with COVID-19. And now we're starting to see a few more patients coming in that are a little bit sicker. I understand a lot of it's a wartime type stuff going on. I understand a lot of those comments, I guess I should say.
And that's true. I'm sure that most of the people throughout the hospital at all the different levels having to deal with this, it's kind of scary. And then you've got to come back home. And if you've got family at home, everyone's worried about, well, do I now make my family sick as well?
Oh, it's like an underlying sense of dread. Now, the one thing I do have to say is it's almost inspiring seeing how these people are working in the hospital, the ER doctors and the nurses, and even the respiratory therapists and the housekeepers and the people that work in the cafeteria, the sense of we have a duty. This is what we do. We have to do this is fantastic. It's why we got into all this stuff, and we weren't called to do this. That's for dang sure. It's taking this stuff home is something that we all worry about. But some of us kind of worried about it before, not to make light of it, but there's lots of nasty stuff hanging around in hospitals. So a lot of us have always been pretty good about washing our hands and changing our clothes and that sort of stuff. This just adds another level of anxiety and stress because it's all you see. And because of the nature of this disease, we've had to change the behavior of literally our entire culture.
And that's very true. So what are you doing different to make sure that people are safe in the hospital?
So we've always sort of maintained, well, if you look historically, it goes back to the AIDS. It goes back to the AIDS issues where we sort of had that. I don't know if you remember the fluid precautions and the contact precautions. And we've always sort of had that dealing with infectious disease. But coronavirus is something new. And the way we're dealing with it is extraordinary. So now we have, for example, coming into the hospital, we have screening stations where people can get their temperatures taken. They can get they can get a quick exam. They can talk it over with a healthcare worker. In fact, at St. Mary's, which is something we have that's kind of cool, we now have a virtual exam where you can log in from home and talk to somebody before you come to the hospital. And that, I think, is one of the key things we can do to what everybody's talking about, flattening the curve. But in other words, it's let's use our resources appropriately to protect our patients, again, because this is something we haven't done before.
And you mentioned in addition to COVID, you've got people coming in for regular care. how should people kind of appropriately decide whether they should go to the hospital if it's not COVID related?
So that's kind of a loaded question, only because if it's not COVID related, I think what a lot, and I get this question almost every day. I can't even walk through a shopping grocery store with somebody without people asking me. So let's separate this into two things. Is it something totally non-infectious disease related? Are you having chest pain? Did you fall and split your forehead on the cabinet? Those sort of things. If you would have gone to the ER before, you go to the ER now. We have too many people that are sitting at home that are afraid to go to the ER because they're afraid of catching something. And what we need to get back to is a little bit of common sense. So if you're sitting at home and you're feeling like a chest pain that you haven't had before, or you slipped and fell and you bumped your knee and now it's swelling a lot and it doesn't look like it's getting any better, if you need to see a doctor, you need to go see a doctor. So we kind of got to get that stuff out of here. But we need to get that stuff out there. What I think you're talking about is if you're sitting at home and you have a fever or a cough or you're not feeling so good, when do you actually go in and get help? And that's something hard. I'll see if I can give you a few little tips for the audience to try to help negotiate these kind of murky waters. First of all, if you have a mild fever, a mild sore throat, a mild cough, something that before all this, you would have been like, oh, dang it. Yeah, I'll probably stay home. Maybe I shouldn't. I'll take some, Tylenol or whatever. Do that. Keep doing that because the likelihood is it's not COVID. It's probably what you had before. Now, let's say you're really sick, like your fever is like nothing like you've had before, and you're starting to feel like you're short of breath, and you've never really been short of breath before when you got a cold. And in that case, you go to the emergency room, and that seems kind of obvious. The hard part is that gray area in between. And there's a couple options people can do. One thing is, let's say it just feels like it's different. Let's say you think this fever, this cough, this something, this isn't the regular one you get every year, a couple months. This isn't allergies. This isn't contact dermatitis or anything. Let's say something about this feels weird. The first thing you should do is contact your primary care provider, contact your doctor or your health plan, because now they have a lot of resources and they can sort of talk you through some stuff. These are people that know you or at least know your history. That's super important. The next thing to do is you may have other options besides the ER. These doctors or your health plan may tell you to go to their office. I'm seeing some patients in my office, even though I'm just, quote, just a surgeon, but they have infectious reasons. They have or infectious problems. They have other symptoms that they kind of want sorted out that may or may help them decide if they need to go to the ER. That's who we stay open for. I'm fairly sure other doctors are doing the same thing. Other options, there are urgent care centers where your physician may send you that can sort of use our resources better in that setting and save the ER for the truly critically ill and super serious patients. Now, phone calls, contact your doctor. If that should start weeding out the type of people that can be treated safely at home, safely at an outside clinic, or need to go to the emergency room. That kind of makes sense a little bit?
It does. And I know having kids and going to the pediatrician, they always worry that your kid's going to get sick in the waiting room. I'm assuming everyone has been taking precautions in their waiting rooms to separate people, and that people should also be smart enough to distance themselves as well as they're going into these places.
That's true. And the slight difference is in a pediatrician's waiting room, it's usually super crowded, and usually the reasons they're there are infectious. Most adult offices and clinics, it's not just infection. It's either asthma or it's hypertension or it's their diabetes. And so the nature of the patients in the waiting rooms sort of is a little different than pediatricians' waiting rooms, which is what we all sort of grew up with as parents. Social distancing is one of the keys to managing this thing. And we're doing similar things in our offices, but by simply not having your routine number of patients, that in and of itself is going to decrease the number of people that are coming in contact. So it's sort of like as a self-fulfilling prophecy right there.
And that it is. So let's just talk about if you're home I know there's been stuff spreading all over the internet about ibuprofen and that you shouldn't take it. What's the truth behind this?
Well, the myths and the rumors regarding coronavirus are spreading faster than the actual virus. It's becoming toxic in and of itself. So, some of it's well intended. A lot of stuff that I see is passed on by physicians and nurses simply because we're desperate for good information. We're desperate for more information. We're desperate for help. And so many people pass and share and repost things that they never source the information. And in this day and age, it is possible for one person to write a letter to one magazine and somehow it goes global. And the ibuprofen story, when we as physicians looked into it, it comes from a letter that was printed in a journal in Britain from physicians in Switzerland and Greece. And the letter supposes a hypothesis. It's merely an idea. And the idea is, and this is getting into the weeds just a little bit, but it shows you how things can get spread so fast, that these doctors started reading some information coming out of China. And we've all heard that people with underlying conditions tend to get sicker, right? So they noticed that people who have diabetes and people who have hypertension tend to do worse with COVID-19. They also noted that they are on a lot of medications because of those diseases. Now, there is a protein called angiotensin converting enzyme, and this one is number 2, so it's ACE2. And that enzyme, that little protein, tends to be elevated in patients who have diabetes and hypertension, mostly because of the type of drugs they're taking for those diseases. So that it's a little protein, ACE2. And when we talk about it's elevated, technically the fancy term is expressed more, meaning our bodies will make more of it. Here's the kicker, is because other studies show that the coronavirus uses that protein, ACE2, to hook onto the cell where it can infect it. So these people wrote, I wonder, is there a relationship between these sick patients, the drugs they take, and the severity of the disease? And maybe they should look into these ACE drugs, because there are ACE drugs that specifically knock down that protein. The problem is, on that list of medications included the word ibuprofen. And because that's the word everybody recognized, they went from that letter, which isn't even a study, it's literally somebody asking a question. It spread across the planet to, oh my God, don't take ibuprofen. And now in Target, the Tylenol aisles are empty and I can get all the Motrin I want. And it makes no earthly sense. And I'm discussing this with physicians who believe it so intensely until I show them on my phone not only the article, but there's a statement at the end of the article where the authors say, this was merely a suggestion and a hypothesis for further investigation. So literally they just wrote, hey, I just had an idea and I was throwing it out there. And this is how this went across the planet. And that's how powerful our social media can be right now.
And that's why I always tell people, you got to go to the source, and it's hard to always find the source. And that just kind of throws up in my mind as a hypothesis. There's drugs out there called ACE inhibitors.
That's okay. So you understand what ACE inhibitors are.
Right.
ACE inhibitors are drugs that we use to control blood pressure and other things in those hypertensive and diabetic patients. And the weird thing is, if you take an ACE inhibitor, it can paradoxically increase the number of those molecules in your system. They just may not work. And it's kind of complicated. And then, again, we don't know any of this stuff, but for all we know, the increase might be trivial. So it may be mathematically increased, but it may be trivial. It doesn't have any effect on the patient. We don't know that. And in fact, none of the evidence afterwards shows that. That's why the CDC and other places have come out vehemently saying there's no evidence, but people seem not to want to believe. And unfortunately, many people who have limited experience reading scientific literature tend to only read the headlines, and they also sort of jump to conclusions. We're a society that thinks we're smarter than we actually are. And when I try not to offend people when I say that, but then I sort of turn it into a joke because I say there'll be 2 words that we will be able to use for the rest of our lives that will indicate how dumb we really are as a society. We think we're smart, but we're really not. And the 2 words are toilet and paper, because there's no earthly reason. There's no toilet paper anywhere because of the coronavirus.
And I think that was another one of those, it popped up and then everyone freaked out and ran out and bought toilet paper.
Oh, you're toilet paper. The gargling with apple cider vinegar. Did you get that one?
I have not.
Yeah, that's not true, by the way. I'm just getting it out there. That ran the gamut. I was hearing that from the nurses in the hospital. The whole chloroquine thing with the president, that's just been a mess of biblical proportions.
Oh, because it's messing up the drug supply.
Yeah, well, first, again, I try to pull politics out of this, but when you're dealing with the entire country, politics matter. And unfortunately, we're getting some mixed information from our leadership, particularly that one tweet that the president wrote about chloroquine being a game changer. And then subsequently, we found out that this Arizona couple got sick and somebody died. We find about people in other countries that were overdosing shortly thereafter. And this is another example of the dangers of social media. And just to sort of frame this a little better, the drug that they're talking about, chloroquine, is a great drug. And people on lupus and people with other stuff use it and depend on it. It also may have some antiviral benefits that we started studying back during the SARS epidemic. And there was literature that suggests that chloroquine and hydrochloroquine may be helpful in treating some of the severe cases of SARS. And since SARS was a coronavirus, understandably, that's where we're going to start our research. Now, this particular problem exemplifies the ibuprofen situation, where the initial data came from a lawyer who wrote a letter in a French journal about how chloroquine has cured X number of patients. When you look at what he wrote, and by the way, he was a lawyer who represents pharmaceutical assets, and his name is Gregory Regano. You can look this stuff up, and I don't understand why people don't. But he started quoting a supposed study that only had 42 patients. And of the 42, only 36 lived. Or no, only 36 finished. Of the 36, 16 didn't get any medications, 20 got hydrochloroquine, and an additional 6 got a Z-Pak. They got the azithromycin. So this person wrote in a Google document, so it wasn't even reviewed by a physician. This was a Google doc that said, hey, I got 6 patients here that all lived and have no evidence of disease after 5 weeks. Out of the people that only took chloroquine, 8 of 14 have no evidence of disease. And interestingly enough, and they don't mention this in the paper, I mean, they mention the paper, but they don't advertise it. Of the 16 people that are left, 2 of them have no evidence of disease either. And they took nothing. So of these 6 people that took both of them that did well, the president tweeted about it, and immediately chloroquine disappeared off the planet, when it's kind of a bogus study. The problem is there is an element of truth, and when people Google it, they will see that there's previous research, that it may have benefits in similar situations, and even the medical community felt pressured into using it, which they're now using it for compassionate use in New York and other situations. The problem, and here's the other limb of the social media danger, is that people don't understand fully what they think they understand. Now, the drug we're talking about is called chloroquine sulfate and hydrochloroquine sulfate. But what many doctors and other people don't know is there's also chloroquine hydrochloride, chloroquine phosphate, and chloroquine diphosphate. And they almost all sound identical. And what's strange is 2 of them are currently used for humans. One is actually used as a fish antibiotic. What's confusing is that drug used to be used for humans years ago, but if you Google it, it might show up, but we don't use it for humans anymore. To make it even more confusing, you make that into a salt. You can mix it in the water in your fish tank to help keep the parasites and bugs off the walls of your fish tank. And if you look at the bottle, it says for quarantining purposes. So dear Lord, if you have a fish enthusiast who has this stuff at home that does a little Googling, they're going to think it's okay. And you can understand why, especially if the president says it's a game changer and people older at home are feeling desperate. You can understand why they would take it and why they may not understand how toxic it can be. And the Arizona couple, where they both got sick and one died, were actually fish enthusiasts. They had koi ponds and stuff. So that's why they had it around. So it kind of pisses me off that people say they shouldn't have taken it because they're just stupid. They're not stupid. Lots of aquarium supply stores have run out of their stocks. And now that you hear on the news, a lot of the people that need the real drug for humans can't get it because it's been hoarded. So you see how it gets super complicated, but when you sit, you take a couple minutes to like explain it and sort of tease it out, it makes a lot of sense, not only to healthcare providers, but to the layperson as well.
And there is a lot of misinformation, and I know that most people don't spend the time to do the deeper research to read. And a lot of the articles, they come up with catchy titles for these medical articles because it's just kind of a thing. But yet when you actually read into the article and you actually dig into it, even sometimes the abstract doesn't give you the full information of what the article says. And when you spend the time to do that, we realize it isn't always what you think it is. And so
you are 100%. Yeah, you are 100% correct there. And in medical school, that's what they train you to do. They train you to read an article and then take it apart, see if it's valid. Just because it's printed doesn't mean you need to adopt it. You need to see if it makes sense. And you're absolutely right. Sometimes the title and the abstract are to get it published, not necessarily to change the world. And some people just don't have the experience and the education to get it. And I think the healthcare professionals, the doctors, the scientists, we need to be better at doing this for the public.
So from a standpoint of people who are now out and about, most people are home, depending on where you are in the country, the rules are all different. What are the smartest things we can do to prevent ourselves and others from getting the virus?
So the smartest thing we can do are the most boring things we can do. And I'm getting a sense that people are getting kind of frustrated hearing that they just need to social distance and wash their hands without understanding those are probably going to be the things that save the most lives. So the coronavirus ends up being kind of wimpy. Soap and water kills it unbelievably efficiently. I kind of joke around saying if you take an ice cream scoop of coronavirus and drop it on your desk and then clean your desk with soap and water, you kill them all. I mean, it works. So the washing of the hands is key. As a side note, one of the reasons that's key right now is we don't have all the information we need in terms of how do we answer the question of how long it stays on surfaces? How long does it stay on a doorknob? And one of the reasons is that research takes time. Science runs by its own clock. And we don't know if it stays longer on a metal surface than a wood surface. Does it stay on fabric very long? Does it have to do with humidity, and does increased moisture allow it to survive a little longer in moisture? There's a whole discussion between aerosolization, which means it's in tiny particles, or droplets, which is larger particles. So washing hands, wiping down surfaces that multiple people touch, that's common sense. It's a great idea. Social distancing makes it harder for people to pass on the virus. So anything we can do to make it harder, we need to do. This is working. The other things that we have done so successful, well, I should say about as successful as we could have hoped, is the closing of the schools, universities, and other large events, because those are great ways of spreading anything, let alone something like this. If you have to go out and about, the being aware of your surroundings, the social distancing, only doing what you really need to do. is key. But just on a personal note, I also believe the stress and the anxiety of this is going to be just as harmful as the virus itself. So I do encourage people when they go outside, using common sense, still get outside. If you have to go to the supermarket to get some food, do it, be smart about it, and try to relieve some of your own anxiety by knowing you're doing the right thing. Don't go to the beach, don't go to a party, but take pride and get comfort in the fact that you're doing the right thing for yourself and for everybody else. I think that's going to go a long way.
And do we know how long from exposure to symptoms?
No. And a lot of this is guesswork. We are literally living in a research study. And every day we're getting new information. We get information from other countries. We get information from within our own country. And synthesizing and analyzing it on the fly is dangerous. It's necessary, but it's dangerous. It's flawed by the nature of the fact that it will change every hour. So we don't know how long it takes in everybody. The idea is if you get it, you should be showing it within 14 days. I've heard as short as 7. I've heard as long as 21. So I think all those different studies, if you kind of average it out, it's kind of 14 days. And it seems to make sense based on what we know about other coronaviruses and other viruses in general. So that's a reasonable expectation. The hard part is, when does that clock start? And we never know when we get exposed, do we? We can make an idea, but we don't know when we get exposed because we can't tell until we have symptoms, and then we start counting backwards. Does that make sense? It's kind of hard to figure out that number. But the short answer is, if you think you've been exposed, you will know within 14 days. If you get symptomatic, that's the other thing, is there appears to be a group of people that never get symptoms.
Do we know why? We don't know why, right?
No, and we never know why that some people get stuff and don't show it. I mean, when the swine flu kicked in 2009, I mean, that affected 1 out of 6 Americans. That was huge. By the time we had 1,000 cases of COVID here, we had 1 million, and the same point with the swine flu. And the swine flu, 80% of the people that died, and that was 13,000 people, 80% of them were under 65, not over. So it was a different animal, but some people still walked around with the flu and never knew it. So is it something with our immune system? Is it something with a particular combination of genetic factors? That's going to take years to figure out. Not now.
And we don't know what percent of people are asymptomatic.
Correct. The only way we can do that is by testing. And well, the only way to do that with absolute precision is to test all 389 million people in the United States. And that ain't going to happen. So I think as we get more test kits, because that is really hindering our ability to collect data and really hurting our ability to advise the American public correctly and to treat our patients properly, is we don't have enough tests. Once we get enough, then maybe we can sit down and do these population studies and say, check everybody in a certain area, or, X number of 1,000 patients, and compare them and get some real large numbers that we can make sense with. But right now we're scrambling. We're just trying to catch up right now.
Once you get it, can you get it again?
So that's a fear that's going around. And the honest answer is, how would we know for sure right now? Because there's so many ways to think that if you get it once and you're good, if you get something else again, is it COVID again? And if it is again, did it actually go away or did it bubble to the surface? So these are all these tests that we can't do real time. We actually need time later to analyze and figure out and get better tests. Just to simplify things, if you have COVID and they test you for COVID, are you testing for the virus? Or are you testing for your body's response to the virus, like an antibody or something else? And those things are different, and tests look for different things. That will help us later figure out more how this virus behaves. But right now, that's kind of an unanswerable question.
Where is the best place for people to get good, solid information?
So I know this country has a grand distrust with media and with our government. And unfortunately, those are the two places we need to go to first, because being honest, the CDC and the World Health Organization are about as clear and accurate information you're going to get in terms of data and in terms of recommendations. Now, what people don't seem to realize is the CDC is changing what they say daily as they get more information to help us out. So there's some really good information. For example, people with asthma, some great stuff on the CDC website in terms of what you can do to help yourself. And they have all this other stuff, and they're adding more every day. I tell all my patients, if you're really freaking out, start there first. When you consume media, whether you get it through your phone, through the television, through your computer, the source is vitally important. And there are some news sources that are better than others. We tend to distrust the media now, and now the pendulum has swung, so we believe what somebody passes on their Facebook post more than what the Dr. Fauci says on CNN, which is not right. I would trust what Dr. Fauci says. I would trust what those people say. The information on CNN with Dr. Gupta and them seems to be more level-headed than, say, the Fox type, the MSNBC ones, those major networks. There's always elements of truth, but all news sources have bias. I would go to the CDC and WHO first, and then go from there. Oh, and interesting enough, local stuff seems to be better than federal stuff, meaning local news is really good at conveying the information clearly and honestly. Our mayors here in LA and Long Beach are doing spectacular jobs. I don't know where you are, but our governor here in California has really been inspirational, where he's actually stood up, really clearly communicated to his constituents on what's going on, what we need, how we're handling it. I'm kind of proud of what our local governments have done. I've seen what they've done in New York. I've seen what they've done in other places. No joke, our local people are kind of kicking ass.
And that's good to hear. I'm in Pennsylvania. We're close to New York, but we're seeing everybody fighting.
Really?
The governor says one thing. The mayor of New York says another. The governor of Pennsylvania says, well, we're not blocking people from New York City coming in. And so it's been a lot of that. What's happened here is a lot of the people who are in and around the New York City area who have summer homes have all scattered to the summer homes. And the problem is the areas where the summer homes are don't have the infrastructure or the people there right now to handle all these people coming in, because they're summer towns. They're not year-round towns.
Wow, you're right. That dawned on us out here in California. So
that has really kind of freaked things out. And the Hamptons are like, no, you can't come into here from the city. But they're all fighting over who can go where and how you can get around. Wow. Certain states, the governors are saying, we're closing, stay home. Certain states, like I'm hearing Florida is saying, it's up to the, each individual area. So you're getting mixed messages. And that's kind of the problem across the board. I think what needs to happen is we all essentially need to shut down, because if you're in an area that's not so infected, over time, you may be. So it's just a matter of the whole timing of all of this. And I guess that's the question, though, is how long are we? Do you have ideas, or are you hearing how long are we really going to have to stamp this down in order to stop the bend the curve and flatten it?
So I will. The two answers to that. One comes from me as a regular old human being who's out here living in the world, and the other one comes as a doctor. And my human one is dying to know when we can breathe. My regular civilian brain wants to know, when can my son go back to school? When can we go to the concerts that got canceled? When can I go, whatever, when can I travel? I want to know. I'm dying to know. Now, my doctor brain says, listen, we had more people die yesterday than the day before. And I could say that statement for the last 6 days. So anybody who's making any sort of prediction now is basing it on computer models where the data is literally changing every day. So how can that be anything reliable? We're comparing data from China and from Italy and from other places when now we are beginning to question that data for lots of other reasons. What I was telling people yesterday or the day before is that there was one day, a couple of, I think it was a week ago, maybe 10 days ago, where the number of cases in China, Italy, and the United States were about the same. At one point, we were all around 80,000. Now, the entire population of Italy is 60 million. The entire population of the United States is about 389, and the population of China is 1.3 billion. But we had the same number of cases at one point in time. So clearly, there's something different. And I wondered if we are busy looking at places that don't apply to us. So the Italy situation is frightening in terms of what's going on there. And there's been so many ideas of like, oh, they're older population, they're higher population of smokers, they have less ICU beds, they weren't ready to handle it. And one of the things we're hearing now is they were too late in doing the social distancing. And if you look at our numbers, are we behaving more like China or more like Italy? We're in the middle, but we're trending more towards the Italy in terms of how it's spreading, especially in places like New York, and hopefully not in other bigger cities like Detroit and Chicago, which we're hearing a bunch of stuff currently with the numbers going up. So whenever I hear the doctors on the news and the media people talking about when it's going to be over, and it's going to be over by Easter. Oh, now we're extending it out to April. Now we're going to go into May. That should tell the public that we're just guessing. We don't really know. We actually just need to hunker down, do what we're doing because it's working. It's definitely working. In California, the early numbers are suggesting that it's not happening here like it is happening in other places, even though we have as many people. And I wonder I'm wondering, it just looks like the social distancing, the staying away from each other, the staying indoors is making an effect. Again, we won't know for a couple of years, but that's what it's looking like right now. Sorry, that was sort of a long-winded answer to a kind of a simple question.
No, that's fine. And the other thing I'm hearing, because originally I think everyone thought they were safe because it was only the elderly, frail, and people with underlying diseases. Right. But what I'm hearing now, either directly from people that I know who are getting sick or anecdotally from somebody knows somebody, that younger people are getting it. And it doesn't seem to be as restrictive. I think I was seeing in the news that there's even a child who got it.
Yeah, you're right. This is the way it may start playing out. We want to say that it doesn't get into kids and it only affects old people because that's simple. And the initial stuff from China was that it appeared from the information they gave us to affect the older people more than, and then there was hardly any younger people. One of the comically bad data points that came out of China was they said it tends not to infect African-American people, which was a rumor going for a while. And nobody bothered to think they don't have a lot of African-American people in Wuhan. So it's sort of an example of false data. I think what we're seeing now is the people that get it earliest and get sickest fastest may be the elderly and the people with underlying conditions. But that doesn't mean the rest of us aren't going to get sick. It also may mean that the younger people may have an immune system that leaves them asymptomatic. It may be that children are able to fight it off better, the analogy being preschool crap. If you have a kid that's in preschool, they all run around with runny noses and it goes away after a while. But if you get sick from whatever they have as an adult, it knocks you on your butt for a week. There may be something about a child's immunology that we don't understand yet. Now, you are right. Younger people are getting it. Why? Because statistically, a lot of us are going to, I'm younger, I'm 55, but we're going to get it. Now, if you look at everybody who gets it, the current numbers suggest that 80% are going to be fine. They're going to get it, they're going to get sick, and then they'll recover. And then the mortality rates, which is kind of a fictitious number, we can talk about that later. The mortality rates are anywhere from 1 to 5 to 10%, which is a horrifying number they're getting out of Italy. But let's just say it's looking around 1%. Well, what do we do with that 19 to 20% that doesn't get better right away and doesn't die? That 20% needs to use a hospital to get better. Those are the people that are going to end up in our hospital. And the question is, are those people going to be the sick, relatively younger people, the people that aren't 80, the people that don't have underlying conditions? Is that where they're going to lie? And that's still a serious place to be. That's maybe what we're seeing now.
And so you were saying something about the numbers not being correct.
Yeah. So because we're limited in our ability to gather information, specifically testing, but also passing information around from region to region, city to city, and countries to countries. But let's say when you do testing, you are going to test the people that are sick first. So you're already kind of pre-screening the healthy people and the people that are mildly sick out of these numbers. So if you only test the sick people, and then those people, some of them die, you are already sort of skewing the numbers towards the people that are already in trouble, I guess I should say. So when you're looking at mortality rates, people tend to compare the number of cases versus the number of deaths. And the hard part there is the denominator, meaning the number of cases is not an accurate number, because we don't know how many people are at home that are positive but don't know it and get better. But we're pretty sure we know how many deaths there are, because that's sort of a real concrete number. There's a body there. You can like put that on a list, but we don't know who's home. And so that bottom number can be really variable. For example, what if for every one person that we test positive, there's 4 at home that got it, but either have something mild, they thought it was a cold, they had the sniffles, whatever, and it went away. What if, and that's I say, what if, we don't know the numbers, but if that's true, the mortality rate drops precipitously. Do you see my point? And so that's when we talk about the mortality rate. It's just right now, it's really hard to wrap our hands around really good numbers.
And that's true. And I'm also hearing the numerators could be wrong. And I don't know if this is true or not. Again, just like everything we're talking about. But it was my understanding that the numbers in Italy were everyone was getting attributed to COVID, even if COVID wasn't the cause of death.
Well, that's pretty much everywhere. That's going to happen because let's say you have, I can give you a concrete example. In Spain, there was a story about 2 or 3 weeks ago that it was a 21-year-old soccer coach that died of COVID. So everyone was like, oh my gosh, it's killing young people. So I read the article, and the article was in USA Today. And if you read the article, it says he died of COVID. And then it says he was feeling sick. He went to the hospital and they tested him and he was positive for COVID. And they discovered he had leukemia right then. And then he died. So my point to you is that he died and he had COVID. I don't think it was the COVID that killed him. He had leukemia and he didn't know it. Now, if he had leukemia, didn't know it, then got COVID and that pushed him over the edge, that's not the same as a 20-year-old healthy soccer coach. That, you see my point?
I do. And that's why I wanted to bring this up, because again, it comes back to people aren't digging in and understanding. So I always say there's the truth and then there is the truth. And so, yes, he died of COVID, but that's not really the truth. The bigger
correct.
truth is he had leukemia. Yeah.
Or maybe the correct word will be died with it, because we are going to find a lot of people, for example, let's say they have a bad heart condition and they get COVID-19 and end up having pulmonary complications, meaning they had to go on a ventilator or they had a really bad pneumonia or something. Now, if you had a normal heart, let's say if you had a normal heart, there is a good chance you could have beat the lung part on its own. But if you had a bad heart, you're going to need your heart to compensate for the work that your lung isn't doing. And if your heart can't compensate, you will die of heart failure, technically due to COVID, but you wouldn't have died unless you had a bad heart. That's how complicated things can get when we're talking about the mortality of this sort of disease. So I think at the beginning, we are going to have to say they died of COVID or because of COVID. But once we start teasing out the numbers later, and we didn't get good numbers on swine flu for 2 to 3 years after it ended, that we'll be able to understand this virus more and hopefully be better the next time this happens, because it's going to happen again. It's going to be something else, but it's going to happen again.
How are hospitals doing across the nation? Everyone's saying there's not enough ventilators, there's not enough masks, there's not enough safety equipment and treatment equipment. What are you seeing and hearing?
There isn't enough. And that's the sad reality is, I mean, for me to say otherwise, I'd be lying. You need to know, though, that many doctors and nurses are being threatened by their hospitals for saying anything to that effect. And even doctors have started losing their jobs and being fired for being in the public eye and saying, I mean, I could get fired tomorrow, but I'm not trying to hurt anybody. We are actually managing with our low supplies at St. Mary's, and most hospitals are really doing the best they can, but we need more. There's no question we need more. Now, ventilators is a different thing than masks and protective gear. Protective gear and masks are something we need all the time right now. The ventilators we need now, but we haven't reached the critical situation yet that they have in Italy. New York City kind of has these very tightly packed places. I'm wondering if, and this sounds kind of more artistic than scientific, but I wonder if the verticality of New York is making it more difficult to treat than sort of the horizontal nature of Los Angeles. The density of people where they're living right on top of each other, as opposed to Los Angeles, which is more spread out with a slightly similar population. I'm wondering if that just makes it physically easier for the virus to spread and physically harder to do the social distancing and isolation. So and that's just me thinking, just talking out of my butt. I'm just wondering if we can explain the difference. Ventilators, getting back to ventilators, you can put a number on that. How many machines do we have? But are these machines we use in the intensive care unit? You also need ventilators in operating rooms. Can we take them out of an operating room and use them for a patient? Yeah, we can. Some surgery centers, which aren't affiliated with hospitals, will have ventilators because they do surgeries there. Can we wheel them out of there and take them to hospitals that are in the area? We probably could do that. We haven't done that yet, but that's an idea. Do we need to make more? And that's where I hope this changes the way we do things in the future, because I think we tend to take our system for granted. We take our health system for granted, and we think it'll always be there until we push it. And we're pushing it, and we don't have this war chest of medical supplies. I really hope this will force us to be better prepared. I'm a little biased because I'm a trauma surgeon. My hospital is a disaster resource center. We work and anticipate for things like mass shooters, bioweapon attack, that sort of stuff. There's actually training that we do through our hospital to prepare people for that. But I guarantee you that suburbia isn't ready for that. You know what I mean? This is affecting everybody. And I hope in the future we will do all this stuff. We will get supplies. We will learn to stockpile. We will put more importance on this and be better prepared when these things hit us in the future. We're okay right now for ventilators. We need more before these surges hit. We also have to share. That's something I don't really hear a lot. But we need to be better as a country. We need to reach out to cities that are next to us and states that are next to us and say, hey, if you're not using them now, can we borrow them? And we'll give them back once our surge is over. And if you need them, you can have them back. I mean, just sort of like the stuff you learned in kindergarten. We kind of need to do that better, and we can do it. And I see it a lot amongst the people in the hospital, but now we need everybody to do this just for now. Let's do this.
And sometimes it just needs someone to mandate that. And I know hospitals in our area are pretty good about sharing drugs and sharing things in the past. And I don't think people have realized what's happened since Obamacare, in that there are tremendous amounts of networks now. So, for example, in our state, there is a massive network. So they've got 30 hospitals across the state, maybe in their network, and they have the ability to share internally then. because you're all part of the same management team. And they have the ability to do that more so than, say, a single standalone hospital like we used to have in the past.
Well, that's sort of funny that you say that, because I've been talking about this for a long time. And my dad, I grew up being the son of a surgeon in a hospital, in a single hospital. But what was weird was, quote, back in the day, the whole get off my lawn kind of thing. Back in the day, the hospitals were independent, but everybody knew everybody and everybody did sort of work together. And then with the advent of HMOs and contracting and insurance companies and all this stuff, it got to the point where, well, if you have this insurance, you have to go to that hospital. And if you have this problem, you have to go to that hospital. And you can't go to the other. And everything sort of got into these silos. Everything got there were walls that were created. And to be honest, infectious disease doesn't give a crap. I mean, disease does not care about contracts. It doesn't care about borders. And I think this is opening to our eyes to the fact that however we want to look at the way we do medicine in the future, we need a better public health system for everybody. And we can figure out better ways of doing it after, whether private insurance pays for private rooms, however we do that. But right now, I think this is really showing that the public needs a better public health system.
That requires leadership, and unfortunately, everyone's fighting.
Yeah, I know. I'm so tired of the fighting.
Is there anything else that we should know about COVID and what we can do that we have not covered yet?
Well, hopefully some of the stuff we talked about at least makes your listeners look at what they're processing and what they're reading about with slightly different eyes. The one thing is it's not that we don't need to worry, we need to be appropriately worried. Do what you can do, because every single person that's doing that social distancing, every single person that's doing the right thing is doing the right thing for more than one person. And that's awesome. We need to keep doing that. But I sort of dumped a bunch of information on you. I think we're good for now.
And thank you so much for joining us today and for sharing.
No, my pleasure. You know how to find me. Call me if you need me.
I hope you found the information helpful. I just want to share a couple more resources and a couple more thoughts as we close this out. Obviously, social distancing works. Culturally, different countries do things different ways. In our culture, one of the things we do is we don't usually wear shoes in the house. If you're going out and you're coming back into your house, we're leaving the shoes in the garage. I'm wiping down the door handles in and out of the house so that we're creating that extra barrier to make sure that we're not bringing things in. Soap and water works. You've heard that. We don't need to get crazy and do this. Just doing the simple types of things is if you can wipe things down, throw away what you're wiping them down with, and don't kind of keep them in your house. The other thing is, and they aren't talking about it, it's the mental effects on our healthcare workers. And if we kind of alluded to it a little bit here today, I've been in the healthcare industry. I was for years. So I've seen the way doctors are treated, nurses are treated, and the changes that have gone on. If you'd like to hear doctors talking about the issues that they are facing as healthcare providers and even nurses and the rest of them, there is a website called KevinMD.com. So it's the name Kevin, MD meaning medical doctor.com. And a lot of healthcare workers across the spectrum are on there talking about what they face as healthcare workers. And as he said, unfortunately, your doctors now work for corporations, and the corporations are telling them how to behave and firing them if they don't follow what they're told to say and not say. So you may not be getting the total truth in open media. So, hey, stay safe, dig into the research, keep things updated. I'm here. You can always email me and ask me questions. I'd love to hear from you. I'd love to hear how your family's doing and that you're all doing well. Hope this is helpful. And again, what we talked about today may be irrelevant tomorrow because something changes that dramatically. It's Rocky at richyoursoul.com. Stay safe, and we shall figure out how to survive this. Have a great day.